Hello, my name is Dr. Sæmundur Rögnvaldsson. I'm a postdoctoral fellow and a physician in Iceland, at the University of Iceland and at the National University Hospital in Reykjavik. I am part of the research team doing the iStopMM study, or the Iceland Screens, Treats, or Prevents Multiple Myeloma study, which is a study which mainly focuses on screening for monoclonal gammopathies in the general population in order to detect early myeloma. But as you know, monoclonal gammopathies also include IgM monoclonal gammopathies. So it actually also includes Waldenstrom's and other IgM monoclonal gammopathies. So the idea behind the study is that we know from randomized trials and also from observational studies that people who are diagnosed with early myeloma at an asymptomatic stage, although a high risk stage, that are close to progressing to active myeloma and get limited duration treatment seem to have superior overall survival. Where we draw the line on who is high risk enough to receive treatment is a little bit of a moving target right now, but we do have some randomized studies showing that. And but the problem is that only around 5% of those who develop myeloma are actually diagnosed at an early stage. And in fact, studies, for example, in the United Kingdom, show that people have had symptoms for a median of 220 days before they're diagnosed with multiple myeloma. So not only are we not diagnosing myeloma at an asymptomatic stage where we can do early intervention, we're actually usually diagnosing it at a quite an advanced stage where people have organ damage that has consolidated and may be irreversible. So that sort of brings us to this question: can we use screening to detect early disease and increase the availability of early treatment? And that's why we're doing the iStopMM study, where we invited everyone in Iceland born in 1975 and before to participate. This is around 150,000 people. It's a small country. And around 54% of the total Icelandic population in this age group gave informed consent for screening. Now, next, they didn't have to do anything, but next time they were at the doctor's office, they were measuring their cholesterol, or they were at the ER due to appendicitis or whatever, and there was a blood draw. We used the centralized blood sampling system in Iceland to order an additional vial of serum to be drawn at the same time. Now, we used this sample for screening, sent it to the UK, where it was screened for with using serum protein electrophoresis and free light chain assays. And those who had an abnormal finding on these assays were then, if it was grossly abnormal, obviously people who had an FLC ratio over 100 or an M protein over 30 grams per liter, they were, we called all of them in. But the rest, which had MGUS by definition, were randomized to three study arms. Arm 1, which is the control arm of the study, where people continue life as if though they were never screened. And then Arm 2 and 3, which we contact, let them know that they have MGUS, and they are then called into clinical follow-up. So we have to date now screened 75,422 Icelanders, and we have found around 3,600 people with MGUS and randomized them to these study arms. And obviously 2/3 of them are then randomized to active follow-up. And we are following these people up in a clinical study center where we're collecting bone marrow and blood samples over time and storing them in our biobank, and also observing them for progression to myeloma, Waldenstrom's, and all that. So the current findings of the study are that screening seems to lead to early diagnosis as advertised, as you would think. So we diagnose people around 1 year earlier when they have myeloma. They are less likely to have symptomatic disease. They are highly significantly less likely to have so severe disease diagnosis in order that they require hospitalization. But so these endpoints matter, obviously, but the more important endpoints like survival and more long-term outcomes, like how much therapy do you need over your lifetime, these variables that we actually need in order to evaluate whether it's economically viable, for example, to do screening, we are still missing those endpoints. But we are quite, what was sort of comforting to see is that we actually looked at people's psychological well-being. So we ask all of our participants once per year how they're doing with regards to anxiety, depression, and so on. And we were quite happy that we couldn't see any effect on that in this group that was notified about having MGUS in a clinical follow-up. They seem to report similar psychological well-being at 6 months, 1 year, and 3 years after their diagnosis. So that sort of is one of the I guess the risks of screening we were the most concerned about, is that people being aware of a pre-malignant state would have decreased quality of life due to that, and we can't see that, at least not using the measures that we are using. But going forward, there are some things that we want to do using this data. I mean, we are trying to both evaluate early detection, early treatment, but we are also trying to optimize the follow-up of people with MGUS, and that includes people with non-IgM and IgM MGUS. But because I think we all know that the pathobiological causes of these diseases is quite different. The biology is different, and the rates of progression is different, and the progression events are quite different as well. So that's what we're doing now. And some of the things that we've already done is that we have created a predictive model for bone marrow outcomes in order to help clinicians and their patients make an informed decision on when to do a bone marrow when they have MGUS. We're working on something similar for imaging, and we have redefined light chain measures and stuff like that. But beyond that, I think the big implication of what we're doing in many ways is that we have gathered this unique screened cohort of people with MGUS with a precursor to myeloma or to Waldenstrom's or something related. And I think by collecting samples again and again over time from the same individuals, from the bone marrow and from the blood, I think we can later go back and observe the biological processes that lead to progression of this benign disorder to malignancy. And I think doing that, we can create better models to predict progression, but I think we can also gain a deeper understanding of these biological processes, which can be helpful when thinking about treatments going forward as well. And that's not just predicting progression, but also predicting senescence. What are the drivers of stable benign precursors? Is it an active process? And if so, can we emulate that process in people with disease? So that's something that we think about quite a lot, and I think we're just really scratching the surface of right now. So there's a lot of stuff going on at the iStopMM study. So stay tuned.